Okay, so I think you already have all these notes. Okay, so we just take a look, general, what is important or which part of the notes or the subject that you have to focus on. Okay, so this is the learning objectives. Okay, the esophagus, you have to know the general features, blood supply, histology, okay, clinical correlations. Also for the stomach, it's the same. So some information regarding the esophagus, okay, a tube, okay. Okay, this one is important. When the esophagus enters the abdomen, okay, it pierces the diaphragm at the level of thoracic vertebra number 10 level, okay, and terminates by joining the cardiac orifice of the stomach. Okay, there are two sphincters of the stomach, okay, sphincters, upper and lower esophageal sphincter. Okay, they are for prevent the entry of air and gastric contents. Okay, okay, let's go. Lower esophageal sphincter at the gastroesophageal junction. The main function of this sphincter is to prevent the reflux of acidic contents back to the esophagus. Blood supply of the esophagus. Okay, it receives the branches from the descending aorta, and the venous drainage of the esophagus will be, the blood will be drained into the azygous system of veins. Okay, so in the abdomen, the blood supply of the esophagus comes from the left gastric artery and also the left inferior phrenic artery. Okay, blood supply again in the venous drainage, okay, and in the abdominal esophagus or at the lower part of the esophagus. This one is very important because there's the portosystemic anastomosis. Okay, so there's two systems here which drains the lower part of the esophagus. One is into the portal circulation, okay, which goes to the liver via the left gastric vein. Okay, and the other one will go into the systemic circulation via the azygous vein. Okay, so these two systems, they meet at the lower part of the esophagus, and if there is a problem with the liver, like a liver cirrhosis, and the blood supply or blood flow to the liver is impeded, okay, so there will be a backflow of blood into the azygous vein, and the azygous vein usually is not like designed to take a lot of blood. Okay, so it will be swollen, okay, and then dilated and tortuous, and this can cause something called the esophageal varices. Okay, so histology, okay, just touch something about the histology. Mainly in the esophagus, the difference at the level, upper 1/3, middle 1/3, and also the lower 1/3. Okay, so these are the main difference. Okay, upper 1/3, mainly the muscle fibers. It is made of skeletal muscle fibers. Middle third, a mix of skeletal and smooth muscle fibers. Okay, and lower third is mainly only smooth muscle fibers are there in the lower third of the esophagus. Okay, so gastroesophageal junction, there's an abrupt transition from the stratified squamous epithelium. So in the esophagus, mainly the epithelium is stratified squamous, okay, just different of muscle composition between the upper 1/3, middle 1/3, and lower 1/3. But the epithelium is the same. This is the stratified squamous epithelium. Okay, and at the gastroesophageal junction, there's abrupt change from the stratified squamous epithelium to the gastric mucosa. Okay, so you can see this one at the left part is the stratified squamous epithelium, and the one going upwards, that one is the gastric mucosa. Okay, so this one I've already mentioned, the origin of the pathophysiology of the esophageal varices due to the two systems of veins which meet at the lower part of the esophagus. Okay, this one I think more related to pathology. Okay, now we come to the stomach. Okay, important thing in the stomach is the where does it lie? Okay, it lies the epigastric, left hypochondriac, and umbilical region. The size, shape, and position of the stomach can vary in individuals. Okay, so parts of the stomach is also important. You have to know where is the fundus, the body, okay, cardia, antrum, and the pylorus. Okay, also very important in the abdomen or the GIT is the transpyloric plane at the level of L1. The transpyloric plane, there's several events are going on in the transpyloric plane. Okay, one of them is the position or location of the pyloric sphincter. Okay, and the level is at the lumbar vertebra number 1. Okay, sphincter of the pyloric sphincter, it lies between the pylorus and the first part of the duodenum, controls the exit of chyme. Okay, another feature of the stomach is there is the greater curvature of the stomach and also the lesser curvature of the stomach. Okay, so greater curvature, it is attached to the greater momentum, right? Okay, so let's see. So this is the greater curvature. Okay, and you can see all this fat layer. This is the greater momentum. So the greater momentum, it is attached to the greater curvature of the stomach. Okay, and the lesser curvature, there's another fold of peritoneum, which is attached to the lesser curvature of the stomach to the liver. Okay, so more specifically the hepatogastric ligament. Okay, so this is the lesser omentum. So remember, lesser omentum to the lesser curvature of the stomach, greater omentum to the the greater curvature of the stomach. Okay, relations of the stomach. Superiorly, it is related to the esophagus and the diaphragm, anterior diaphragm, greater omentum, okay, anterior abdominal wall, okay, left lobe of liver. And the more important is the posterior relation of the stomach, also known as the stomach bed, okay. So let's see the stomach bed. Okay, so you can see the black line. This is the outline of the stomach, and you can see that behind the stomach there's some important structures. Okay, diaphragm, spleen, splenic artery, also the left kidney, left suprarenal gland, pancreas, and also a part of the transverse colon. Okay, blood supply of the stomach. Not that complicated. Okay, so 4 main blood supply: right gastric, left gastric, right gastroepiploic, and left gastroepiploic. So the question may come like, what is the origin, okay, of the right gastric or left gastric? Okay, so the right gastric comes from the common hepatic artery, left gastric comes from the celiac trunk, right gastroepiploic from the gastroduodenal artery, and the left gastroepiploic artery is from the splenic artery. So you can see there's 4 arterial blood supply, okay, and each of them, they arise from different artery. Okay, so this is the blood supply. So that's the left gastric artery, and then the right gastric artery. Both of these gastric artery, they supply the lesser curvature, and we have the right and left gastroepiploic artery. Okay, epiploic means the greater omentum. Okay, epiploic. Okay, so this right and left, they supply mainly the greater curvature of the. Okay, blood supply of the stomach, again, the vein, okay, right and left gastric vein drain to portal vein, the short gastric vein and right gastroepiploic vein is they drain to the superior mesenteric vein. Okay, nerve supply mainly from the parasympathetic, the vagus nerve. Okay, so it controls the what we call this peristalsis and also the secretion of the gastric content, okay, enzyme Okay, sympathetic nerve from the celiac plexus and the greater splenic nerve. Okay, so the lymphatic drainage, it follows the arterial blood supply. Okay, right and left gastric node. Okay, and the right and left gastroepiploic node, and also the short gastric node. Okay, so this is histology. Okay, stomach mucosa, gastric pits and glands. So you can see there's the isthmus, neck, and base of glands. So what is important in the stomach mucosa is the location of the cells and their what do you call this function. Okay, so certain cells they are more prevalent in the isthmus. Okay, some are in the more in the neck, and some are in the base of the gland. Okay, so you have to know this. Okay. So epithelium, simple columnar epithelium. Okay. So there's the what do you call this? Gastric pits. Okay, gastric pits. So let's see again the gastric pits. Which one is the gastric pit? So this upper part is the gastric pits, and the one with the isthmus, neck, and base of gland. Those are the gastric glands. Okay, fundus and body of the stomach. Mainly there's the parietal cells. Okay, parietal cells, they secrete hydrochloric acid. Okay, and also there's the mucous neck cells, resemble surface mucous cells, but they secrete the mucus for lubrication of gastric contents and also protection from the hydrochloric acid. Okay, chief cells, they are located at the base of the glands, and these chief cells, they secrete the enzyme, which is mainly pepsinogen. Okay, so let's see again. Okay, mainly in the isthmus or the neck is the mucous gland. Okay, in the neck, those are the parietal cells, which secrete hydrochloric acid. Base of the gland, mainly the chief cells, which secrete the pepsinogen. Okay, parietal cells, okay, the how to describe them? They are described as a fried egg appearance. Okay, so you can see, okay, the fried egg or the yeah, fried egg with the yolk. Okay, so a large nucleus, and also there's a pink colored cytoplasm. Okay, those are the parietal cells which secrete hydrochloric acid. Okay. Clinical correlation also, okay, this one can lead to peritonitis if there is perforation of the stomach wall, okay, and then mainly it will go and infect the stomach bed, okay, so that's why the stomach bed is quite important. Okay, so that is all regarding the esophagus, and also the stomach. Any question before we go to the next one, which is the urinary? Okay, so in the urinary and reproductive module, I teach the kidney, ureter, and also the prostate, male reproductive system, and also the bony pelvis. Okay, so let's go through each of them. Okay. Okay, so these are the learning objectives: gross anatomy, okay, urinary bladder, and also the prostate gland. Okay, kidney, retroperitoneal organs, right kidney lower from the left kidney due to the presence of liver. Okay, anterior relations, okay, right kidney is different from the left kidney. At the top, it's the same suprarenal area. On the right side, mainly there's the liver, okay, duodenum, and also for the colic area means the right colic flexure, okay. On the left side, okay, we have the suprarenal area, and then the spleen, gastric area, pancreas, and also the colic area, okay, and also a large part at the lower part of the kidney, we have the colic area. Posterior relations are more or less the same for both kidneys. Okay, it's the difference, the right kidney is only related to the slightly lower than the left kidney. So it is only related to the 12th rib. Okay, compared to the left kidney, 11th and 12th rib. Okay, we have diaphragm, okay, and also three muscles. Psoas major, most medially, then quadratus lumborum, and also transversus abdominis, plus two nerves, iliohypogastric nerve and ilioinguinal nerve. Okay, renal fat, there are four layers of renal fat. Renal capsule directly just adjacent to the kidney. And then we have the perirenal fat, okay, which encompasses both the suprarenal and the kidney. And then the renal fascia, okay, and also the outermost fat layer is the pararenal fat. Okay, so the renal fascia, it covers all the top part, okay, anterior, posterior part of the right kidney, and also it is continuous with the opposite side. Okay, so both the right and left kidney have this fascia, and the fascia is continuous. Okay, except for the lower part, the inferior part of the fascia, it is not closed. Okay, so it is not does not blend together. Okay, the two layers do not blend, so the kidneys can move up and down during the diaphragm or during the respiration. Okay, so all direction of the kidney and suprarenal gland are covered by this renal fascia, except for the inferior part. Okay, so this one, if you like take the kidney and then cut it into half. Okay, we have the renal hilum. Okay, from anterior to posterior, very important. Which structure is the most anterior? Vein, anterior artery, and also the pelvis of ureter. Okay, internal structure also is important. Okay, we have the cortex. Medulla is made up of renal pyramids. In between the pyramids, we have the renal columns. Okay, apex of the pyramids are called renal papillae. Okay, so these are the flow of the urine. Okay, so in the cortex, there's mainly the renal corpuscles, and then the urine is produced or filtered. Okay, and then it goes into the pyramids, and then from the pyramids, it goes to the this renal papillae and into the minor calyces, and then major calyces, and finally into the pelvis. Okay, arterial blood supply, very easy. Right and left kidney for respective kidney. Venous drainage from the right and left renal vein. Okay, so here, left and right renal vein drain into inferior vena cava. On the left side, okay, so the renal vein receives two additional vein, which is the left suprarenal vein and left gonadal vein. Okay, so these two veins on the left side, they drain into the left renal vein. Okay, on the right side, these two, right suprarenal vein and right gonadal vein, they go directly to inferior vena cava. So take care of these two differences between the right and left renal vein. And then we have these segments. Okay, this one is for additional, what do you call this, information. Okay, if there is surgery and the surgeon wants to isolate a part of the kidney, so he can do that. Okay, because of the arterial blood supply. Okay, some clinical correlation. Okay, now we come to the ureter. Okay, muscular tube conveying urine to the bladder. Okay, it descends retroperitoneally. There's an abdominal pelvic part. Blood supply of the ureter. Okay, it receives branches from the major arteries which are near to it. Okay, so from the top, maybe from the top, it receives branches from the renal artery, and then the middle branches from the descending aorta, and then at the middle or the bottom, it receives branches from the uh, common iliac artery and also the interior iliac artery. Okay. Pain from the ureter refers to the posterior abdominal. Okay, so it will go to the according to the level of the ureter where the stone is going. Okay, so these are the pain referred to the posterior abdominal, below the ribs, okay, above the iliac crest, scrotum, and labia majora, according where stone is attached to or stuck in the ureter. Okay, so areas supplied by this area will refer the pain to all these areas. This is another important thing, uterine artery. Okay, the relation between the ureter and the uterine artery. Okay, so the term water runs under the bridge. So the water is urine. Okay, the bridge is the uterine artery. Okay, so ureter is going below the uterine artery. So this is important, this knowledge, because the uterine artery is uh, will be gated and also clamped. Okay, so you know, so um, you want to what do you call this? Know the anatomy. Okay, so always the uterine artery is above the ureter. Okay, this is also important clinically. Okay, where is the ureter constrictions? Please remember this. Okay, there are three main sites: at the pelvic-ureteric junction, at the pelvic brim, and as the ureter goes into the bladder. Okay, urinary bladder. Okay, you're something about the urinary bladder. It is okay. The parts is also important. Which one? Apex, superior, inferolateral, base, and also the neck. Okay, trigone of the bladder, the characteristic. Okay, the smooth and the sensory rich of the trigone area. Okay, it prevents urine from flowing backward into the ureter. Okay, this is easy to understand. Okay, behind the internal urethral orifice, there's a fold, and this fold can enlarge in what you call this benign prostatic hypertrophy. Okay, and then we have the area called the cave of Retzius. Okay, just behind the symphysis pubis, and this cave or space allows the what you call the surgeon to go into the bladder without piercing the peritoneum. Okay, so we do not want to go into the peritoneum. There's a risk of peritonitis, sepsis, and all that. Okay, so next is the detrusor muscle, which is making up the bladder wall, and then nerve supply, parasympathetic nerve for emptying of the bladder, and then sympathetic nerve relax the detrusor muscle and constrict the internal urethral sphincter. Okay, so this is the clinical correlation. Next, we have the prostate gland, okay, chestnut-shaped gland at the neck of the bladder. So it secretes thin, milky alkaline fluid in the when during ejaculation. Okay. Okay, this one is also important. The lobes. Okay, two lateral lobes, one middle lobe, one anterior lobe, and one posterior lobe. Okay, because the lobe is where some disease happen. Okay, like by benign prostatic hypertrophy, and then we have also the prostatic cancer. Okay, so in the prostatic urethra, okay, there's a enlargement called the seminal colliculus, which the two ejaculatory ducts and prostatic utricle open. So there's an opening. There's an opening for the ejaculatory ducts. Okay, which is made up of the vas deferens and the seminal vesicle. Okay, and the opening is called the this ejaculatory ducts. Okay, and also there's a very what you call it, there's openings also for the prostate gland. Okay, for the secretion of the prostate gland, and all the secretion are secreted, okay, in this area called the seminal colliculus. Okay, blood supply and nerve supply. Blood supply from the inferior vesicle, middle rectal, and internal pudendal artery. Okay. Um, Nerve supply, sympathetic and parasympathetic. Okay, both hypogastric and pelvic plexus. Okay, so the prostate is very near to the rectum, and this one is per rectum examination of the prostate. Okay, clinical correlation. The medial or median lobe is involved in the benign prostatic hyperplasia, while the prostate cancer occurs most commonly in the posterior lobe. Okay, so you have to know and remember these two differences. Okay, which lobe is related to which disease of the prostate. Okay, so any question before we go to the male reproductive system?
Doctor, I want to ask a question.
Okay,
For the posterior relation of the left kidney, does
yes.
left kidney also related with iliohypogastric and ilioinguinal nerve?
Yes. The answer is yes. They were right and left have this right and left iliohypogastric and ilioinguinal nerve.
Oh, okay, thank you, doctor.
Oh, okay. Any other question? So actually, we have a pair of ilioinguinal and iliohypogastric nerve, right and left. It's just in the picture. I just show you the only on the right side. Okay, let's go to the next topic. Okay, anatomy of the male reproductive system. We'll just go through quickly and see which are the important structures. Okay, so we have to identify and describe all these testes, epididymis, vas deferens, seminal vesicles, penis, and scrotum. Okay, so this is the male reproductive system. Okay, another view of the male reproductive system. Yes, I want to emphasize, okay, this is the ejaculatory duct. The ejaculatory duct is made up of union of the seminal vesicle and vas deferens. Okay, so these two, seminal vesicle and vas deferens, they will join and then they will form the ejaculatory duct, and this ejaculatory duct will open in the seminal colliculus in the prostate gland. Okay, and during ejaculation, all these three will provide the fluids. Okay, semen. Okay, and then ejaculation happens. Okay. Okay, testis. Okay, it is what do you call this? There's a tough white fibrous capsule called tunica albuginea. Okay, surrounding the testis. Okay, and this tunica albuginea, it partition all the inside of the testis into lobules. Okay, in each lobule there are highly called seminiferous tubules, and in this inside the tubules the sperm are produced. The sperm are produced inside these seminiferous tubules. Okay, interstitial cells which produce male sex hormone are located between the tubules. So the sperm is produced inside the seminiferous tubules, okay, and there are cells in between the tubules, okay. They produce the male sex hormone or the testosterone. Okay, blood supply or arterial blood supply is from the abdomen, okay, which is called the testicular artery. Okay, so in male, it is called testicular artery. In the female, it's called the ovarian artery. Okay, or the general term, it can be named also as the gonadal artery. Okay, other blood supply is the cremasteric artery and also artery to the vas deferens. Okay, venous drainage. Okay, there's a lot of very little, okay, veins called the pampiniform venous plexus of vein. They surround the testis and drain the vein, blood, okay, and inside into the right testicular vein. Okay, okay, so right testicular vein, it goes into the inferior vena cava. Okay, remember the kidney, renal artery, renal vein. Okay, left side or left testicular vein, it goes into the left renal vein. Okay, nerve supply also comes from the abdomen, from the T10, T11, what you call this, level. Okay, so that is why there's a referred pain. Okay, so if the scrotum is hit, the pain is felt in the abdomen. Okay, at the T10 and T11 level or area. Okay, next is the epididymis. We have the important thing is the head, body, and the epididymis and tail. Okay, and the function. Okay, so head function is to absorption and concentration. Body of epididymis for sperm maturation. Tail is for storage. Okay, vas deferens is a tube connecting the tail of the epididymis to the ejaculatory duct. Okay, so we have the scrotal part, spermatic cord part, okay, pelvic part, and ampulla. And the most important is the ejaculatory duct, where the vas deferens joins the duct of the seminal vesicle to form the ejaculatory duct, which opens into the prostatic urethra or the seminal colliculus. Okay, so this is regarding vasectomy. Next is the seminal vesicle. It produces 60 to 70% of the semen volume. It is located behind the prostate, okay, merge with the vas deferens to form the ejaculatory duct. Now we come to the external genitalia, penis and scrotum. Okay, please remember which one is the corpus spongiosum, which one is the corpora cavernosum. Okay, the corpora cavernosum is attached to the pelvic bone, okay, while the corpus spongiosum is rest on the perineal body. Okay, penis is actually a erectile tissue. Okay, each crust of penis is attached. Okay, this one is the corpora cavernosa. Okay, and the urethra actually is inside the corpus spongiosum. Okay, this is a cross section of the penis. Each cavernous body has an outer fibrous covering. Okay, similar to the testis, which is called the tunica albuginea. Okay, and superficial to the tunica albuginea is a very important fascia called the Buck's fascia. Okay, and this Buck's fascia, okay, you can see it combines or binds all the three erectile tissue together. Okay, arterial supply mainly by the internal pudendal artery and the penis. Okay, deep arteries of the penis run in the center of the corpora cavernosa, okay, supplying the erectile tissue. So you can see in the corpora cavernosa that in the center there's the deep artery, okay, while in the corpus spongiosum at the center there's the urethra. Okay, deep arteries involved in erection. Okay, there's also in the erectile tissue something called the helicine arteries, and what these arteries they are engorged. Okay, makes the penis to erect. Okay, but when there's no blood inside the helicine arteries, these arteries are coiled. Okay. Okay. Okay, this one is to show the arterial supply. Okay, dorsal artery, deep artery. And then venous drainage, deep dorsal, superficial dorsal vein. Okay, sensory and sympathetic, mainly by the pudendal nerve, parasympathetic by the prosthetic nerve plexus. Okay, scrotum, what is important is the layers. Okay, the layers from the skin, dartos muscle, dartos fascia, external spermatic fascia, cremasteric muscle, okay, internal spermatic fascia, and parietal and visceral layers of tunica vaginalis. Okay, so all these layers, they come from the abdomen. So you can like correlate or associate the different, like the cremasteric muscle fascia, they come from the internal oblique muscle. External spermatic fascia comes from the external oblique muscle. Okay, internal spermatic fascia comes from the transversalis fascia. Okay. This one is regarding dartos muscle, okay, a superficial fascia of the scrotum, which gives the wrinkled appearance of the scrotum. Another muscle, which is called the cremasteric muscle, it actually raises up the scrotum close to the body when there's cold temperature. Okay. Okay, this is the clinical correlation. Hydrocele is the because due to of the patent or open processus vaginalis, which peritoneal fluid goes into the scrotum. Okay, varicocele is the enlargement, engorgement of the pampiniform plexus of vein, mainly on the left side. Okay, because the renal artery is smaller than the inferior vena cava, and the second one is the left. We call this vein, gonadal vein. It goes at the straight angle or right angle, 90 degrees into the left renal vein. So the flow is slower. Okay. Torsion is the twisting of the testis on its own axis, and this can cause blood supply disruption to the testis. Okay, so next one, the last part is the regarding bony pelvis. Okay, so what is important in the bony pelvis? How to differentiate the false and true pelvis? Okay, what is pelvic inlet, pelvic outlet, and pelvic cavity? Okay, and also to know the hip bones, ilium, pubis, ischium. Okay, this is some of the part. The most important thing is the ischial tuberosity. Okay, you are sitting on the ischial tuberosity, pubic arch. Okay, okay, this one some information. Okay, division of the pelvis, greater pelvis and lesser pelvis. Lesser pelvis is inside this very restricted area or the blue area. Okay, the greater pelvis is from the iliac crest over here. Okay, and the upper part is bounded, okay, externally by this red line. And this red line is called the pelvic inlet or pelvic brim. Okay, so false pelvis or greater pelvis, bounded by iliac fossa, iliacus muscle, anteriorly by the abdominal wall. Okay, and the content is the coils of ilium and large intestine, psoas and iliacus muscle. Okay, lesser pelvis is inside this blue area. It has an inlet. This red line is the inlet, and then we have the pelvic cavity inside and also a pelvic outlet. Inside this, there is the urinary bladder and reproductive organs such as uterus, ovary, and also the prostate gland, seminal vesicle, and all that. Okay, so you have to know the difference between greater pelvis and or false pelvis and true pelvis. Okay, and the border is the pelvic inlet or the pelvic brim, and also the content of the greater pelvis and inner pelvis. Okay, so this is the pelvic inlet. This is the border, symphysis pubis at the front, sacral promontory at the back, and also iliopectineal line at the sides. Okay. From the bottom, we have there's the pelvic outlet, is a diamond shaped. okay, posteriorly bounded by the coccyx, anteriorly by the pubic symphysis, and also laterally by the ischial tuberosity or ischiopubic ramus. Okay, pelvic cavity. Okay, so between the pelvic inlet and pelvic outlet. Okay, so these are the borders. Okay, contains the ureter, urinary bladder, rectum. Okay, some blood vessels and nerves. Okay, differences between male and female pelvis, you already know. Okay, but the main thing is the shape of the pelvic inlet to identify, right? And also the pubic arch and subpubic angle. In male, the pubic subpubic angle is less than 70 degrees, and in female, it is more than 90 degrees. Pelvic inlet in the male is a heart shape, and in the female, it is oval shape. Okay. Okay, you can see the male pelvis, heart-shaped pelvic inlet, and the subpubic angle is between 50 and 60 degrees, which can be represented by the two fingers, second and third finger. Okay, while the female pelvis, the inlet is more oval in shape, okay, and the subpubic angle is 80 to 85 degrees, okay, and can be represented between the first and second finger. Okay, so this some pelvimetry to measure the pelvic inlet, mid pelvis, and outlet. Okay, and the importance of this is to estimate the pelvic adequacy if the baby can go through the pelvis or not. Okay, so that is for my part. Any question before I um pass this session to Dr. Prof. Timonwe? Okay, so I'll ask her to come in.